Next up, we're going to move on to the next group of antibiotics. These are the ones that affect cell metabolism, namely by targeting folic acid synthesis. Let's start with sulfonamides. Examples of sulfonamides are sulfamethoxazole, sulfasoxazole, and sulfadiazine. This image shows the simplified pathway for cell metabolism. PABA, or PABA, ultimately makes tetrahydrofolic acid. This goes on to make purines as building blocks to be used in DNA and RNA, thymidine to be used in DNA, and methionine as a building block for proteins. Go back and review your basic biochemistry if you are unclear on this. Sulfonamides inhibit dihydropteroate synthase in this step that I've pointed to here. They act as PABA antimetabolites that are bacteriostatic. Clinically, they are used for gram-positive and gram-negative organisms, as well as nocardia. Sulfamethoxazole can be used for simple UTIs, while sulfadiazine is topically applied to burns. Sulfonamides may induce hypersensitivity reactions, hemolysis in G6PD deficient patients, nephrotoxicity, and kernicterus in infants. I'll tell you about a favorite question on the boards, which will have a patient that starts a sulfur-containing drug that then develops hemolytic anemia. I'm going to tell you that you should always check which antibiotics a patient is on when a patient suddenly becomes sick. In this case, the hemolytic anemia was caused by the sulfur-containing drug as a result of G6PD deficiency. Bacterial resistance is a result of altered enzymes, decreased uptake, or increased PABA synthesis. Let's talk about the other drug that affects metabolism, trimethoprim. TMP is bacteriostatic and inhibits bacterial dihydrofolase reductase in this pathway we just discussed with sulfonamides. Without dihydrofolate reductase, bacteria are unable to generate methyl groups and therefore cannot synthesize certain nucleosides such as thymidine and other nucleotides for DNA and RNA synthesis. This indirectly inhibits transcription and cell division. Trimethoprim is frequently used in combination with sulfonamides such as TMP-SMX, aka Bactrim. It is used to treat UTIs. Do you remember in what other situation TMP-SMX is used in the context of immunocompromised patients? That's right, it's used for the prophylaxis of pneumocystis jirovecii pneumonia as well as toxoplasmosis. One important side effect is that trimethoprim also affects human dihydrofolate reductase, but to a lesser extent than the bacterial version, so you may need to administer folinic acid or leucovorin to alleviate the side effects of megaloblastic anemia, leukopenia, and granulocytopenia. Go back and look at hematology if you are unclear what megaloblastic anemia is. You can use the mnemonic TMP or trimethoprim for treats marrow poorly. For the same reason, trimethoprim should not be taken during pregnancy. Okay, so another flash quiz. I just want to help you draw this in. Both SMX and TMP affect cell metabolism. SMX inhibits this enzyme, while TMP inhibits this other enzyme. You know this. SMX inhibits dihydropterate synthase, while TMP inhibits dihydrofolate reductase, or DHFR for short. Okay, so now we're going to move on to the next group of antibiotics, the fluoroquinolones. These antibiotics target DNA synthesis. So in this group, we're going to start with the quinolones and the fluoroquinolones. There is only one quinolone whose name you need to remember, and that's nalidixic acid. All of the other fluoroquinolones end in floxacin or just oxacin, and they're easy to remember for that specific reason. Fluoroquinolones are bactericidal antibiotics that inhibit DNA gyrase. This is the basic structure of quinolones. If this fluorine molecule is present, then you know it is a fluoroquinolone. Fluoroquinolones typically are used in the treatment of gram-negative rod, urinary, and GI tract infections, as well as Neisseria and some gram-positive organisms. For example, levofloxacin is considered to be a respiratory fluoroquinolone because it can access pulmonary tissue. It is used for pneumonia caused by strep pneumonia, Legionella, Mycoplasma, chlamydia pneumonia, and H. influenza. Common reactions to fluoroquinolones include GI upset, skin rashes, headache, and dizziness. Less commonly, it can cause tendinitis, tendon rupture, and myalgias. Tendinitis and tendon rupture are unique adverse effects of fluoroquinolones, and this is a high-yield fact worth remembering. So, what did I just say? That's right, tendinitis and tendon rupture. Those are key adverse effects of fluoroquinolones that you should remember. So, one way to help you remember this is the mnemonic fluoroquinolones hurt the attachment to your bones. This will help you remember the fact that tendinitis and tendon rupture are high-yield facts associated with fluoroquinolones. Animal studies have shown damage to cartilage, which is why these drugs are contraindicated in pregnancy and childhood. Metronidazole is our next antibiotic. It is a bacterial antibiotic that induces free radical toxic metabolites, which thereby damage bacterial DNA. It is effective against anaerobes and also has antiprotozoal activity. Remember that I drew this squiggly diagram. It indicates that above the diaphragm for anaerobes you will use clindamycin, while below the diaphragm in the GI tract you will use metronidazole to treat anaerobes. So for metronidazole, as I mentioned, it is used for protozoal infections. Giardia is an example of an infection for which metronidazole is used, which is shown here in this diagram that I just indicated. It is also used for entamoeba, trichomonas, Gardnerella vaginalis, and anaerobes such as Bacteroides fragilis. It is also used in the treatment of H. pylori. This image here on the right shows H. pylori along the luminal surface of gastric epithelial cells. Do you remember what other antibiotic treats anaerobes? Right, I just mentioned it. It's clindamycin. I'll repeat one more time. Clindamycin is used to treat anaerobes above the diaphragm, such as aspiration pneumonia caused by Prevotella, which is an oral bacteria, while metronidazole will treat those below the diaphragm, such as the GI tract, for example, B. fragilis. One more question. What adverse reaction does clindamycin result in? That's right, it's C. diff infection. And which antibiotic are you going to use when you get C. diff infection? That's right, it's metronidazole. So keep these two anaerobe fighting antibiotics straight in your head. Also note that if you get C. diff, vancomycin orally can also be used to treat C. diff, but you'll generally use metronidazole in the milder cases of pseudomembranous colitis, whereas vancomycin is only brought in when you have life-threatening cases of pseudomembranous colitis. Why would we not want to use vancomycin up front? Well, I mentioned to you VRE, or vancomycin-resistant enterococci. We'd want to use vancomycin less often to prevent formation of these VRE organisms. Also note that metronidazole is used as triple therapy in the treatment of H. pylori. Another thing to note is that metronidazole may induce a disulfiram-like reaction, which will include flushing and nausea with concurrent alcohol intake. I know you're ready for another flash quiz. Metronidazole forms part of triple therapy for H. pylori. What is triple therapy? Is it A. PPI, bismuth, metronidazole, B. azithromycin, tetracycline, and metronidazole, or C. PPI, azithromycin, and metronidazole? The answer is C. A PPI, azithromycin, and metronidazole comprise triple therapy for treating H. pylori infection. And so that's it. We're done with the antibiotics used to treat bacterial infections. We're now going to move on to antimycobacterial drugs, those used to treat infections such as TB. So, let's go through the three organisms which are targeted by antimycobacterial drugs, namely M. tuberculosis, Mycobacterium avium intracellulare, and Mycobacterium leprae. Let's start with Mycobacterium tuberculosis. M. tuberculosis colonies are shown in this image. Let's go through this table to look at Mycobacterium tuberculosis. Isoniazid, aka INH, is used both in the prophylaxis and in the treatment of Mycobacterium tuberculosis, which is the causative agent in TB. Prophylaxis in this circumstance is treatment of latent infection to prevent symptomatic disease. The mnemonic RIPE is helpful in remembering the drugs used for treatment against M. tuberculosis: rifampin, isoniazid, pyrazinamide, and ethambutol. These 4 drugs are used as initial therapy for 2 months, and then 2 drugs, namely isoniazid and rifampin, for 4 months. The way I like to remember it is that you use 4 drugs for 2 months, and then you use the first 2 drugs for 4 months. Remember the RIPE mnemonic to help you remember these drugs. In this image, acid-fast stains are shown of Mycobacterium avium intracellulare. Looking at this table, we see that azithromycin is used for both prophylaxis and treatment of M. avium intracellulare. It is an important organism which is of particular importance in immunocompromised patients. Other examples of treatment are rifampin, ethambutol, and streptomycin. These important medications will be discussed in more detail in a little bit. Lastly, in this image, we'll see acid-fast stains that are shown of Mycobacterium leprae. Dapsone and rifampin are used for the treatment of Mycobacterium leprae in the tuberculoid form. You're going to add clofazimine when you have the lepromatous form. Note that there is no prophylaxis for Mycobacterium leprae. So now we're going to go through these drugs that I just mentioned, starting with isoniazid. Isoniazid, also for short INH, inhibits the synthesis of mycolic acids that are part of the cell wall of Mycobacterium tuberculosis. This is illustrated in this image. INH actually requires conversion by catalase peroxidase into the active metabolite that will then inhibit mycolic acid synthesis. I've written this out for you to illustrate my point. Realize that mutants of TB that do not have this catalase peroxidase activity will therefore be resistant to isoniazid. Isoniazid has a number of clinically important side effects, including neurotoxicity and hepatotoxicity. Do you know how you can prevent any of these side effects? Right, they can be prevented by the co-administration of pyridoxine, aka vitamin B6. I've written out the mnemonic that will help you remember the important side effects of isoniazid, namely that it injures neurons and hepatocytes. Also note that isoniazid can cause drug-induced lupus. If you don't remember what lupus is, refer to rheumatology for a better description. Also remember that isoniazid inhibits cytochrome P450. It's easy to remember because isoniazid will inhibit P450. Next we have rifamycin, which inhibits DNA-dependent RNA polymerase, as illustrated in this image. It is clinically used against Mycobacterium tuberculosis and as an alternative to dapsone against Mycobacterium leprae. Rifamycin is used in addition to dapsone in multiple drug therapy. The reason for this is that rapid resistance develops if it is used alone. When you see rifamycin, think of the 4 R's. So let's go through these 4 R's. We already mentioned 2 of them. First, it is an RNA polymerase inhibitor. Second is that resistance develops rapidly when it is used as a sole agent. The third R is that it can cause red-orange bodily fluids, including the urine, which is quite traumatic if you see it. Finally, it upregulates or revs up cytochrome P450, which is the 4th R. Is this the same way that isoniazid works? No, remember, isoniazid inhibits cytochrome P450, so it is the exact opposite. Think about the implications of this if you're using the 2 of them together. Along with rifamycin and isoniazid, pyrazinamide is another drug used to treat Mycobacterium tuberculosis. This is an electron micrograph image of the ultrastructure of TB bacilli. The mechanism of pyrazinamide is uncertain. It is particularly effective in an environment with an acidic pH, such as phagolysosomes, where TB is found after being engulfed by macrophages. The toxicities of pyrazinamide include hyperuricemia, leading to possible gout, as well as hepatotoxicity. Ethambutol is the final drug in the 4-drug therapy. Remember the mnemonic RIPE, so it is the E in the RIPE to treat M. tuberculosis. It works by blocking the enzyme arabinosyl transferase, which ultimately decreases synthesis of the cell wall of Mycobacterium tuberculosis. Remember that the unique toxicity that can be caused by ethambutol is optic neuropathy, specifically red-green color blindness. To help you remember this point, I've put an image here for you. Individuals with red-green color blindness would have difficulty identifying the number 37 in this image. I hope that you can see it. Great, it's time for another flash quiz. Let's go over the therapy for TB. I'm going to help you drill this in. What is the treatment regimen for TB? Name the agents and their duration. How does this therapy regimen change after this period of time? Great, I'm so glad that you know the answer. The treatment regimen for Mycobacterium tuberculosis is rifampin, isoniazid, pyrazinamide, and ethambutol for 2 months, followed by just rifampin and isoniazid for 4 months. Remember the mnemonic, 4 drugs for 2 months and then 2 drugs for 4 months, and those 2 drugs are the first 2 of the letter RIPE.